Topic for discussion is ischemic heart disease. As we all know, ischemic heart disease is also called as coronary heart disease. It is usually caused because of various etiological factors such as atheromas, that is nothing but atherosclerosis, or because of any thrombosis, congenital anomalies like fistula, malformation of major coronary artery, aortitis, polyarteritis, etc. This is a picture showing normal artery. In a normal artery, what happens when the arterial cross section is taken, the lumen is normal in size, so it will allow the normal perfusion of the blood. But whenever there is narrowing of an artery because of deposition of the fatty material which is leading to atherosclerosis, the result of that would be narrowing of the lumen of the blood vessel. So whenever there is a narrowed artery, the blood flows with a more amount of pressure, and also there will be less amount of perfusion to the adjacent tissue to which it has to be supplied. So whenever there is a decrease in the blood perfusion, it can lead to ischemia, and thus it can lead to ischemic related diseases, and if it occurs in a heart, it is called as ischemic heart disease. So this is a picture showing an animated picture which is actually showing the flow of blood vessels there. But as there is a narrowing of the blood vessel there, the flow of the blood is being restricted through the side. Okay, and it can also further lead to thrombosis because of that plaque material which is being occluding the blood vessel, thus it can result in obstruction to the flow of the blood. Now, what are the various risk factors that are actually causing this ischemic heart disease? One is age factor. As age increases, risk of atherosclerosis is more, and in men when compared to women, risk of atherosclerosis is again more, maybe because of the habitual histories or the lifestyle. And then family history plays an important role because most of the times it can be familial in nature. Smoking, obesity, sedentary lifestyle are much risk factors for formation of atherosclerosis or atheromas within the blood. And metabolic syndrome that comprises of hyperlipidemia or any lipid disorders, diabetes mellitus, hypertension, and various hemostatic variables can also pose risk for ischemic heart diseases. And there can be certain dietary deficiencies such as any antioxidant deficiencies or vitamin deficiencies. PUFA deficiency, that is polyunsaturated fatty acid deficiency, can also lead to formation of atherosclerosis that further leads to ischemic heart disease. So what is this atheroma? What is atherosclerosis? Atherosclerosis is nothing but a patchy focal disease of the arterial wall. Here what happens is usually coronary arteries are at higher risk in this atheromas, whereas radial artery and mammary arteries are usually not much affected. Here whenever there is hyperlipidemia within the blood, monocytes will absorb the low density lipids, forming lipid-laden foam cells. And these lipid-laden foam cells will, in the flow of blood, will actually migrate towards the arterial wall and gets deposited there. In due course of time, the lipid-laden foam cells will undergo apoptosis in the natural course of the cell cycle. When they undergo apoptosis, what happens? The fatty material that is being present within these monocytes will come and get attached to these walls. Whenever there is an apoptosis, there are extracellular lipid pools are formed, and there will be atheromatous plaque there. And this atheromatous plaque which is formed there for a longer period of time, when it stays, it will actually cause blockade of the blood vessel, and in due course it can cause thrombosis, thus leading to vasospasm. Whenever this thrombus gets ruptured, it can form into embolus or emboli, and they cause acute coronary syndromes. So this is actually a picture showing cross section of a healthy artery, and there is fatty material degeneration on the vessel wall. Once there is excessive fatty material degeneration, if at all there is an arterial wall tear, this can lead to further hemorrhage or hematoma, forming a blood clot which will totally occlude the blood vessel there. This can lead into acute coronary syndromes or acute coronary diseases here. What are the various clinical features of these acute coronary or various ischemic coronary diseases? It can lead to stable angina, unstable angina, myocardial infarction, and it can lead to heart failure, arrhythmias, and sudden death can also be one of the clinical manifestations of these diseases in severe cases. And how can we prevent these coronary diseases? Prevention can be done by lifestyle changes. Primary prevention can be by changing the lifestyle, especially modifying the risk factors such as smoking, chronic alcoholism, exercise to the body, identify and treat high-risk individuals, more obese patients or patients who are mostly into sedentary lifestyle, who does not exercise, who have the dietary food is of high calories. These patients are to be identified and treat the high-risk individuals by modifying the risk factors. The secondary prevention is also present, where we have to ask the patients to cess the smoking. Smoking cessation has to be done. Aspirin, as prophylactic aspirins and statins have to be given to these patients, and beta adrenoreceptor antagonists can also be helpful in secondary prevention of coronary diseases. Now coming to myocardial ischemia. Myocardial ischemia presents as various clinical manifestations such as angina pectoris. In this angina pectoris, we have stable anginas and unstable anginas, and let us first deal with stable anginas. Angina, the Greek word angina means strangulation. It means a choking effect. Okay. Normally, it is a discomfort due to transient myocardial ischemia. Here what happens is, in these patients usually, there will be an imbalance between oxygen demand and oxygen supply. There is more amount of requirement of the oxygen, however, there is less oxygen supply. So why does this occur? It is because, as we already saw, this thrombus, which is the atherosclerosis or the atheromas, which are causing blockade of the blood vessels, will lead to lower perfusion, less amount of perfusion to the areas that require more amount of oxygen. So at this time what happens, the tissues which has to be perfused require more oxygen. However, there is less oxygen supply because of the blockade of the blood vessel there. It can manifest, it can be one of the manifestations of hypertrophic cardiomyopathy or aortic valve diseases also. Hence, angina pectoris has to be differentiated whether it is caused because of an ischemic disorder or because of a hypertrophic cardiomyopathy or other aortic valve diseases. What are the various risk factors of this angina pectoris? They include smoking, hypertension, hyperlipidemia, mixed edema, diabetes, obesity, anemia, thyroid disorder, cardiomegaly, elevated venous pressures, peripheral vascular disease, and carotid bruits are various risk factors that are causing this angina pectoris. And one other thing which is most commonly seen is peripheral arterial disease. And in this picture we can see whenever there is a normal artery there, however in atherosclerotic artery what happens is there will be decreased perfusion to the end organ, to the target tissue. Hence, this will cause peripheral arterial diseases. Coming to the clinical features, in stable angina itself means that there is central chest pain, and this will be precipitated based on exertion or excessive workouts. After this exertion, whenever patient is resting, there will be relief in the discomfort. So this is stable angina. Patients usually complain with a sense of tightness, especially band around the chest. They usually deny pain. They say there is discomfort. They feel heaviness on the chest. There is a band, there is a tightness over the chest region. So this is what they actually complain of. Patients also have referred pain to the arm, especially the left arm, to the wrist and also to the fingers, especially the little finger. And they also sometimes get confused with the epigastric pain or intrascapular pain, because even the ischemic pain also manifests as an epigastric pain and interscapular pain also. And these symptoms usually worsen after meals, in cold weather, and walking up hills. And there are various types of angina. For example, startup angina, also called as warm-up angina. In this type of angina, what happens is patients usually feel the discomfort when they initiate walking, when they start walking or when doing the exercise or doing some physical activity. Later, once the pain has developed and it gets subsided, after that, even when patient does much greater effort, more strenuous exercise also, patient will not have the angina manifestations. So this is called as startup angina or warm-up angina. It usually occurs only during the start period of that episode, where during the initial periods of the episode, and does not continue or does not come up again even when patient performs more strenuous exercise than the starting one. And they have also decubitus angina. Decubitus angina, in this condition, patient will have the discomfort when patient is lying flat or when he is sleeping. Okay, this is called as decubitus. And we have something called nocturnal angina, usually seen during the night times, and during the daytimes it is lesser in occurrence. And we have something called as Prince metal angina, or variant angina. Prinzmetal angina or variant angina is a condition where patients usually have this angina, the angina effects on the ECG transiently. They will not have a continuous angina properties there. Usually we can say transient ST elevation in the ECG in case of Prinzmetal or variant angina. So this is an ECG showing a transient, we can see a ST elevation here in these cases of Prinzmetal angina. Now coming to the differential diagnosis of stable angina, we have pericardial pain, we have musculoskeletal in origin, and esophageal pain, which may be because of esophagitis or esophageal spasm. So we have to differentiate between these three, and also through the with the ischemic stable angina. Now, what are the investigations that we actually do to evaluate angina? One is resting ECG. In resting ECG, we can see T-wave flattening, which is actually a non-specific evidence of myocardial ischemia. There can be a reversible ST segment depression or elevation with or without T-wave inversion here. And we have something called as exercise ECG, also called as treadmill rest test or exercise tolerance test. Here what happens is we actually, as a patient, to perform this, a standard treadmill or bicycle ergometer where planar or down sloping ST segment depression of 1 mm is seen, and this can indicate ischemia. And we have something called as isotope scanning. Isotope scanning is usually done in cases where there is uninterpretable exercise test, and in those cases what we do is we do a myocardial perfusion scanning. Here patient will be injected technetium, that is radioactive IV technetium 99 will be given here, and normal if there is a viable tissue, the viable tissues will actually perfuse, they take this material. In a non-viable tissue we actually see like a void there, a negative space. So in those cases this will be helpful. Isotope scanning will be helpful in those cases where where we cannot interpret an exercise test. And other tests includes echocardiography and radionuclide blood pool scanning, which will help in measuring ventricular function. So echocardiography and radionuclide blood pool scanning will help in measuring the ventricular function in cases of any to check any ischemia in these cases. And we have something called as coronary arteriography, which will actually give us complete information about the anatomical structures and the nature and extent of coronary artery disease. It is usually done when we actually wanted to perform a coronary bypass surgery or angioplasty. Now, this is a picture of coronary angiography where we actually insert a catheter inside the leg and it's guided up to the aorta. And the catheter tip stops at the left coronary artery. We can see it in this picture number 2, and then this contrast agent is injected into arteries, and X-ray imaging shows if there is any stenosis in the left coronary artery. So this is nothing but coronary angiography. And coming to the management of this ischemic heart disease, aspirin acts wonderfully in cases of any angina. 70 to 300 milligrams, which is a low dose, will actually reduce the risk of adverse events like MI. And anti-anginal drug therapy can also be administered where nitrates, beta-adrenoreceptor agonist, potassium channel activators, and calcium antagonists are usually given. There is something called as sublingual glyceryl trinitrate, that is GTN, where aerosols, it is available as aerosol and tablet form. Aerosol, which is a nasal spray, about 400 micrograms nasal spray is available, per spray is available, and we also have tablets which can be taken orally for 300 to 500 micrograms. This relieves angina in about just 2 to 3 minutes of time. It is also available as percutaneous patches or paste, and it is also available as slow release buccal tablets of about 1 to 5 milligrams for about 6 hourly time. IV nitrates can also be given, that is nitroglycerin 0.6 milligram per hour can also be given in case of severe anginas. And we have beta blockers or beta adrenoreceptor antagonists, which will actually lower the myocardial oxygen demand by decreasing blood pressure. Here what happens is, as we already know, angina is because there is a imbalance, that is more demand for oxygen and less supply. So what it is this beta blockers will actually lower the myocardial oxygen demand by decreasing that blood pressure, heart rate and contraction of myocardium. So examples of beta blockers includes, as we know, atenolol, sustained release also is present. We also have metoprolol, which is about 200 milligrams daily. And there is something called as beta blocker withdrawal syndrome when beta blockers are used and they're suddenly withdrawn. Hence, in those cases, what we have to do, slow withdrawal of beta blockers has to be done, and replacement of this drug with any other drug is possible. I mean, with any other drugs such as nitrates or calcium antagonists can be done. Calcium antagonists usually they inhibit the slow inward current which is caused by entry of extracellular calcium through the cell membrane. It will lower the myocardial oxygen demand. Here also it will be helpful in decreasing the myocardial oxygen demand in case of calcium antagonist. Examples of calcium antagonists include nifedipine, amlodipine and nicardipine. Now coming to the invasive treatments. Okay, now we have till now we have seen how medical management can be done. Let us go to surgical management or invasive treatment management. We have something called as coronary angioplasty, and we also have stent or balloon angioplasty and coronary artery bypass grafting. By these two things we can also remove of the atheroma or atherosclerosis there. For example, in this picture we can see coronary heart is actually located. We can see a plug which is present. In doing this coronary angioplasty, we inject a stent. We actually take a catheter inside and they will be having a stent or balloon to it. After going inside, the stent is being expanded or the balloon is inflated there. By doing this, what happens? The narrowed down artery will be enlarged here. Okay, the compressed artery which has been present where the new narrowing of the lumen has happened there. By passing the stent into that, we can actually enlarge the lumen. Thus, reperfusion of that area can be seen. This is nothing but angioplasty, coronary angioplasty. Now coming to unstable angina. Unstable angina is a condition where there is rapid worsening of angina, also called as crescendo angina. Here what happens is patient will have severe angina even at rest, not even even though there is no much of stress, physical activity or anything, patient will still have severe angina even on rest. This is called as unstable angina, and this can be prolonged and severe ischemic chest pain can be seen in these cases. Usually unstable angina is because of thrombosis, where there will be abrupt reduction in the coronary blood flow leading to supply-led ischemia. If you remember, stable angina is a demand-led ischemia, whereas unstable angina is a supply-led ischemia. ECG here shows ST and T wave changes, that is nothing but ST depression we can see, transient ST elevation we can see, and we can also see T wave inversion in these cases. Coming to the management, similar management to that of stable angina, where in this management 10 to 15% of risk of death or acute MI is present. Hence, unstable angina's treatment or management has not to be neglected. Bed rest, aspirin, beta adrenoreceptor antagonist has to be given. Heparin in case of high risk cases has to be given to prevent the flow of to prevent any thrombus formations, and coronary arteriography and coronary bypass grafting will also be helpful. Now coming to the oral manifestations. Oral manifestations, most of the times as we have discussed, angina can radiate to mandible or teeth. If patient is having severe teeth pain, gnawing, dull gnawing type of pain in the teeth or especially in the mandible without any cause of dental issue, think about angina. Get an ECG done, check for the risk factors, and then you can almost save a patient's life if at all you suspect an angina in those cases. Nitroglycerin when taken within the mouth can cause burning or facial flushing and headaches can be seen in these cases, and these oral manifestation can also occur like chemical burn. Nitroglycerin when placed under the tongue can also cause chemical burn of the within the oral mucosa. And we also can see xerostomia because of, as a secondary effect to the ducts, drug-induced xerostomia, especially when patients are using diuretics, calcium channel blockers and ACE inhibitors. And lichenoid drug eruptions are more common with thiazides and beta blockers. Coming to aspirin and antiplatelet therapy, if patient is on aspirin or any other antiplatelet therapy like clopidogrel, etc., we'll have to suspect excessive bleeding when you are performing an elective dental surgery. So whenever you are performing an elective dental surgery in those patients, take a physician consent, check for INR. If INR, that is international normalized ratio, is within the normal range, you can go ahead with the treatment procedures. However, always be ready with the local styptics and anticipate bleeding there, so that you will be ready with the all the precautions that you can take to minimize bleeding in those cases. If at all INR is high, then refer the patient to the physician, and patient is advised to stop the drug if needed based on the physician's approval if the INR is greater than 3. And we also can see gingival hypoplasia, especially patient is using calcium channel blockers. We can see gingival hypoplasia in these cases, and if at all there are more number of inflammatory factors, gingival hypoplasia can be aggravated. Hence, maintenance of oral hygiene is very important, and professional oral prophylaxis has to be done in those cases. Also, if at all the drug induced gingival hypoplasia is severe, and refer the patient to the physician and advised to change the drug to another form, okay, another antihypertensive, which will thus reduce the gingival hypoplasia. So what are the various dental considerations when a patient of ischemic heart disease come to us? First, remember, any stress or anxiety can provoke angina in those patients. So make the patient, talk to the patient, make the patient comfortable, and try to relieve the stress and anxiety of the patient. In cases if it is needed, advise a pre-medication of any anxiolytics, so that patient, like tricyclic antidepressants or etc., the patient will be relieved out of tension and can be comfortably sitting on a dental chair and take a dental treatment. And short, minimal, stressful dental appointments are usually advised. Late morning appointments are useful in these patients. Avoid excessive dose of LA, especially that contains adrenaline, in patients taking beta blockers. Severe dental caries and periodontal diseases are most commonly seen in these patients. Hence, regular dental checkups are advised to the patients. Pre-medication with anti-anxiety drugs will also be helpful. If at all patient develops angina on a dental chair, what do you do? So, terminate all the dental treatment. Always have your emergency kit handy in the dental office. Position patient in a semi-reclined position. Give nitroglycerin tablet, about 0.4 milligrams tablet or a spray. Administer oxygen. Meanwhile, call for emergency or medical assistance, and always keep checking pulse and BP of the patient, and call for medical assistance and shift the patient immediately to a hospital. So this is how you can actually manage a patient on the dental chair. Do not panic. Firstly, calm down and make the patient calm down. Make him or her in a semi-reclined position and give a GTN, and it works wonders. Next, coming to myocardial infarction. Myocardial infarction is due to formation of an occlusive thrombus at the site of rupture of erythematous plug in the coronary artery. Here, it will lead to an irreversible myocardial infarction. It is usually potentially fatal. It can lead to death, and many early deaths are because of ventricular fibrillation. We have various clinical features of myocardial infarction, which includes pain, breathlessness. Patients will have vomiting, anxiety, and they collapse on the floor. Arrhythmias or profound hypertension can lead to syncope in these patients. Vagal stimulation can lead to sinus bradycardia and vomitings, because especially in case of inferior myocardial infarction. Sometimes, especially in older patients or diabetic patients, we can see something called as silent or painless myocardial infarcts, and this can be dangerous sometimes. And there will be signs of sympathetic activation, especially when seating, and patients will become paler and we can observe tachycardia within them. Fever or raised jugular venous pressure can be seen, and we can hear a third heart sound. Hypotension, oliguria, lung crepitations, diffuse apical impulses. We can also see mitral regurgitation and pericarditis in cases of myocardial infarction. Ventricular fibrillation and asystole can lead to sudden death in the patients. Extent of myocardial damage will reflect the severity of the cardiac failure. What are the investigations that we do for cases of myocardial infarction? ECG, that is nothing but electrocardiography. Here, in early stages, we see changes like ST elevation, diminution of R wave, and in the later cases, we see development of Q wave and T wave inversion. There are certain plasma enzymes that are usually elevated in these cases, which include creatine kinase, that is CKMB, and troponin T and I. We also see aspartate transaminase, that is AST, and LDH, that is lactose dehydrogenase, also being elevated in cases of myocardial heart disease, myocardial ischemia. And we have leukocytosis and raised ESR, chest radiography, whether it's pulmonary edema, cardiomegaly, And we have cardiac ultrasound or echocardiography. This will help us to assess left and right ventricular function. And we have something called radionuclide scanning, which will be useful for left ventricular function. Now coming to the management of myocardial infarction. In myocardial infarction, firstly defibrillation. Bed rest has to be advised to the patient. Avoid excessive or avoid any strenuous exercise. Oral aspirin, which will enhance the thrombolytic activity, thrombolytic therapy effect, and the intravenous opiates can be given. High flow oxygen will be helpful in reperfusion of the ischemic areas, and thrombolytic drugs which will restore the coronary patency, reperfusion, and relief of pain. Anticoagulants such as subcutaneous heparin, which is about 12,500 units twice daily for 7 days. Warfarin can be given. Beta adrenoreceptor antagonists can be given, and various nitrates, that is nothing but GTN, can also be given in these cases. We also have other drugs such as streptokinase, which is 1.5 ml in 100 ml of saline given as IV over 1 hour. And we also have altiplase. Altiplase is nothing but human tissue plasminogen activator, that is nothing but TPA. And surgical process or invasive process includes angioplasty, where immediate or primary angioplasty has to be done in case of myocardial infarctions. And we have risk factors modification in case of to prevent the secondary MIs. And we have coronary arteriography and bypass grafting can also be done in these cases. So this is a picture of echocardiography, usually done for left ventricular defects. So what are the common complications of this MI? The common complications include arrhythmias. Arrhythmias are mostly of various types, which include ventricular fibrillation, ventricular tachycardia. We can see accelerated idioventricular rhythms, ventricular ectopics, and we also see arterial tachycardia and fibrillation, sinus bradycardia, and heart blocks. We also see other complications such as ischemia. Ischemia like post-infarct angina and residual stenosis can be seen, and acute circulatory failure can be seen. Pericarditis. In this pericarditis, post-myocardial infarction syndrome or Dressler syndrome is seen. We also see embolism, impaired ventricular function, remodeling, and ventricular aneurysms. So this is all about your myocardial infarction or all of the ischemic heart diseases. We have seen how they manifest. Ischemic diseases manifest, especially coronary artery diseases, which manifest as angina, stable angina, and how its complications as myocardial infarction, and how we treat a patient with angina, management of angina patients, and if such patients come to a dental office, how do we actually manage patients with ischemic heart diseases, and what if an angina occurs on a dental chair. We also have seen how to manage patients who had an attack of angina on the dental chair. So this is all about ischemic heart diseases. Thank you.